Good evening, everybody, and welcome to our special edition webinar tonight of No Endo, Egg Freezing and Endometriosis. I'm so excited about this one because it's something that I get asked about all the time, so it's obviously best that we hear it from the expert. Before we start, we just want to acknowledge the people of the Kulin Nations, the traditional custodians of the land upon which we work and care for our patients. We honour the unique and continued spiritual connection that Australian Aboriginal and Torres Strait Islander peoples have to land, waters and culture. We're so honoured to have Prof Jim Soltis with us tonight. Prof Soltis is a highly regarded advanced laparoscopic surgeon and fertility specialist with main research interests in endometriosis, adenomyosis, fibroids, and the impact of these disorders on fertility and IVF. So very relevant to us tonight. Prof Soltis is the training director at Monash and the Australian Gynecological Endoscopy and Surgical Society laparoscopic training program and has been the AGES president. You all probably know me, the endometriosis coordinator here at the Epworth Endometriosis Centre. It's always a pleasure to be with you. I hope that everyone's comfy and cozy at home. You've got your heat pack, you've got your tea, you've got whatever you need, and you can just enjoy with us tonight. A little bit of housekeeping before we start. In regards to language that we use, we acknowledge that not everyone with endometriosis identifies as female. And as much as we try and avoid the use of the term women, we do acknowledge that non-binary, gender diverse and intersex people, and in some really rare cases, cis males can also suffer from endometriosis. So this is for everybody. If you've got a question, there's a Q&A box, should be up on the right-hand corner of your screen. Just drop a question in there throughout because you might be prompted while we're speaking. We'll get to those at the end. Unless it's really relevant, I'll interject, but we'll try and save it till the end because I'm sure that we're going to cover a lot. And then we'll get some discussion going. So feel free. And this will be recorded there. It's completely anonymous. We can't see you. We can't hear you. We will ask questions anonymously, so we won't use your name at the end. And then this will be able to be shared later on after. So that's enough from me. I'm very happy to hand over to Prof Jim Soltis, and thank you so much for being with us tonight. I know you've had a busy day, so we're very lucky to have you on your evening.
Firstly, Nikki, I want to thank you and Jace for inviting me to present what I think is a really very important topic and should be part of the conversation for many of our patients. And hopefully we can cover that a little bit as the evening goes on. And as you say, really the questions and queries of our patients are the most important thing, and to really empower them and give them as much information as we can from the Epworth so they can make an informed and relevant decision for their own personal circumstances. So again, thank you. And I will skip through some slides, but I will slow down at what I think are the most relevant ones. So what I wanted to talk about was to talk about the current status of fertility preservation techniques, their applicability to endometriosis, some of the knowledge that we have about the impact of endometriosis on ovarian reserve, and look at strategies to improve fertility outcomes. I have no conflicts of interest related to this talk, other than the fact that I do work at Melbourne IVF. This slide is certainly very relevant. This looks at an ovary, and it looks at the eggs within the ovary. And if you can see my pointer, this is an ovary at birth with many eggs within it. This is at 25 years of age, and we already have a reduction. At 25 years of age is when we really have our peak AMH, and I'll talk about that a little bit later. By the time we get to 50, the number of eggs that we have are significantly reduced. So this is very important when we think about egg freezing and also our ovarian reserve, when we would potentially want to have babies and when we want to freeze our eggs. So, and that's really very important. An article in the New England Journal of Medicine, and New England Journal of Medicine is a very senior journal which talks really, if you see an ONG article in it, it means that the editors of this journal feel it's very relevant. And the main summary of this is that women, obviously they're using the term women of reproductive age, really need to think about freezing their oocytes, and that they say that the possibility of elective cryopreservation of oocytes, which means freezing your eggs, should be discussed with all women, females who are in their early 30s, since the number of available and genetically normal eggs continually decreases over time. And so we really need to be talking to our patients, and I think that women, by the time they get to 30, should be having this conversation with their families, with their friends, with their peers, and really talking about what they as individuals want to do. There's no right or wrong answer. I think the right answer is you should actually work out whether this is right for you or not right for you. People thought, if we freeze our eggs long term, are there going to be any problems? And the word aneuploidy means, is my embryo going to be genetically abnormal? Obviously, the most common abnormality that we hear about is Down syndrome, only because people know about it from the media. So aneuploidy is when you have an incorrect number of chromosomes within your embryo, and freezing your eggs long term does not actually increase or change your risk of having an abnormality. It's purely based on your age and doesn't change by the fact that your egg stays frozen. So if I can digress for a minute and talk about, does endometriosis itself impact ovarian reserve? Is this really a fact, or is it a controversy? Does endometriosis in any location have an impact on ovarian reserve? And really, what's been published to date? So I'm going to talk about non-endometriomas. So endometriomas are big cysts of endometriosis in the ovary, and that a paper back in 2008 suggested that if you had endometriosis, that you actually had a lower AMH, or AMH is anti-Müllerian hormone. It's a marker of your ovarian reserve. Is this, however, true? Another study suggested that the more severe endometriosis was, that your AMH may in fact be lower than your colleagues, friends, peers who are of the same age as you. And certainly the studies now are showing that minimal to mild endometriosis doesn't appear to impact your ovarian reserve, but severe endometriosis without endometriomas may, because of inflammation within the pelvis, actually impact on your ovarian reserve. I think what will come out in the future is, if you're genetically driven to have severe endometriosis, and we now look at subtypes of endometriosis, are you actually going to have less eggs, and are they not related to there's not a cause and effect? In other words, the endometriosis hasn't caused your low ovarian reserve, but women who have severe endometriosis may also have a genetic predisposition to have a lower number of eggs, but that will become more obvious. Obviously, when we look at AMH, that it may be a marker of the severity of the disease. The study that showed this was looking back at the patients. And again, you should be thinking about the AMH of your patients when you're talking about their surgery and about their future fertility. And this is what the AMH does. And this is a big scatter graph, and you can see in individuals it can be very different, but your AMH rises from birth. It peaks at age 25, and then your AMH will slowly drop down until you go to menopause. So certainly at 25, I would not check somebody's AMH unless they wanted it checked. From a medical perspective, we would certainly start checking it if patients want it at 25. I have, however, had a number of patients who I've frozen their eggs at 20 who said to me, Jim, I'm really stressed about this. Can I have my AMH checked? And I'll say, not a problem. And they obviously had a gut feeling and knew something about themselves that I didn't know as a doctor, and their ovarian reserve was very low. I always doubt the test, and I repeat it in a different laboratory. And if in fact it's very low, we start talking about, why is that individual's AMH very low, and should they be thinking about egg freezing? Are they the patient that's going to go through menopause earlier rather than through the normal time frame? Is it, however, just endometriomas that actually cause a low AMH? And we know that endometriomas themselves are responsible for a reduction in your ovarian reserve before the surgery, and we know as a consequence of surgery. And there was an excellent paper published by Charles Chapron Jr. in Paris in 2012, and this is an excellent review study. Now, how do endometriomas cause damage? So this is a pictorial. This is out of the United States, where this is a pictorial of the endometrioma releasing a whole lot of factors that actually causes accelerated follicular development and atresia, in other words, shrinking and death of your eggs. So when people say, I've got an endometrioma, should I treat it, and they haven't had a family, I think that they should, because if you allow the endometrioma to grow, it will actually continue to damage your ovarian reserve. And then we're faced with the quandary that when we operate, we will also cause a little bit of damage to the ovary. And so the AMH may drop further, but it's a bit of a catch-22 situation. If you leave the endometrioma grow, it will cause irreversible damage, while the surgical damage is finite. And then we look at strategies to try and reduce the recurrence of endometriomas. So this particular patient has bilateral endometrioma. So here's her uterus here. Here's a large endometrioma and a smaller one on the other side. She also had bowel endometriosis. You can see the bowel come up, tucked up behind the ovaries here. And she had a very low ovarian reserve to start with. But as you can see, her tubes were normal, and she fell pregnant after the surgery spontaneously, having struggled to fall pregnant for a long period of time. But certainly, if she hadn't fallen pregnant, we would have moved to IVF earlier. Or if she wasn't planning to get pregnant, we would have then frozen her eggs. And you would not freeze eggs with huge endometriomas like that. The risk of infection within the ovary from IVF is very high, and you need to deal with these first before you consider egg freezing. So is there a way we can improve egg numbers? And there was an excellent study that was done through Europe where they looked at CoQ10, and CoQ10 has been the only thing that may potentially improve your ovarian reserve. You're not going to go from being able to only get 5 eggs with IVF to 20, but you might get 6 or 7, and it may be that 6th or 7th is the magic egg that gets you pregnant. So it is important that we think about, if I see a woman with a low ovarian reserve and we're planning IVF treatment or egg freezing in the future, that we look at CoQ10, which is readily available at good pharmacies at 300 milligrams twice a day. And I look at this picture, and is your egg immortal? And in a sense, it's true. So here we have a little cartoon of an egg being frozen. What this is an electron microscopy report of meiosis. So what happens is that we have 46 chromosomes. If the egg and the sperm joined together with 46 chromosomes, we'd have 92 chromosomes and we'd be a different species. So we have to split our chromosomes. So this is a young egg that's splitting its chromosomes. You can see the spindles of the chromosomes are very, very, very clear, and they're very ordered. This is a woman who's over 40 and her spindles are disordered, and that's why you get chromosomal anomalies. And therefore, the younger we freeze our eggs, the better it is, and you'll see that in the outcomes that I'll talk about in a minute. And again, that's a close-up of the same aspect of the age-related effect on egg quality, and that's why our natural pregnancy rates, our miscarriage rates all increase as we get older. So this was a study back in 2014. So this is early on in the process, and they looked at how the eggs survived, and they looked at the number of patients, and we looked at survival, and that we looked at donor cycle, so from someone who's donating, someone who using their own eggs, and eggs that have been frozen. And at that stage, and this still holds true, that 80% of your frozen eggs will survive and actually go on to be used in subsequent IVF cycles, as opposed to fresh eggs, where obviously the vast majority of eggs survive the IVF process. You have more eggs to work with. But certainly this was most encouraging, where 80% of your eggs were actually surviving. Now, I've been involved with egg freezing for many, many years now, from when we did it and there were no pregnancies and no survivals of eggs, to now where we have an 80% chance of a live birth, and I'll talk about that in a moment. So this is real-time data to 2019, that we have an 85% survival rate if you freeze your eggs under the age of 35. And obviously, once you're over 35, you have a lower chance of your eggs surviving than if you freeze them when you're younger. This study in 2016 showed the live birth rate, depending on the number of eggs that you had, and according to your age. So if you're 35 or under, if you had 15 or more eggs, you had an 85% chance of having a baby. If you're over 35, you had a 35% chance, which is still outstanding because we've come from a point where we had no pregnancies. And this is the latest data out of Sweden, that if you freeze your eggs under 34, you've got a 90% chance of having a live baby. You then have a 66%. This is having 20 eggs. So that's the magic number. We want to bank 20 to 25 eggs. Obviously, that's not achievable for everybody. And you've even got a chance of a third baby from those eggs. At 37, high for the first, but often you'll get a big drop. But even at 42, you've got a reasonable chance of one live birth, but the chance of a second pregnancy or a third is extremely small. So really, before you hit 35, if you have the opportunity, or even if you're under 40, you should be thinking about freezing your eggs. And I can see Nikki thinking, I've got questions. So this is an excellent, excellent graph which shows your chance of pregnancy. This is a predictive algorithm depending on your age and how many eggs you freeze. And it's all coloured. So if you're a young donor donating to your sister, so if you're under 30 and you're donating, if you give your sister 20 eggs, she's got a 90% chance of having a baby, okay? If you freeze your own eggs, often you don't do it that young, you're still pretty good if you're under 35, and you've got, if you freeze 20 eggs, you've got a 90% chance of pregnancy. Now this is the best one down here. This is if you're 44, that you need 100 eggs, which you're never going to get. It might take you years, and you'll be 46 all of a sudden, that to actually have a 40% chance of pregnancy. So if we actually look at 20 eggs, you've got a 15% chance of pregnancy if you're 44. So ideally, you can see there's a big drop, and you want to be freezing, you know, really under the age of 38. You've still got very high pregnancy rates. And we know, again, leading on, that IVF can't make up for older eggs. So that when you're over 42, your chance of spontaneous conception is almost the same as IVF. And obviously, we will talk very carefully with our patients about how they should proceed down those pathways. Now, endometriomas, they're critical. They're big cysts of endometriosis. If you've got 2 endometriomas, it's far worse, because if you've got 1 endometrioma, you've then got a normal ovary, and you've at least got half your normal ovarian reserve. What we do is we check the ovarian reserve. We look at whether it's one side or both sides, the size. And so if you have a huge endometrioma, we actually now don't just go ahead and operate. If you've got a 10 centimetre endometrioma, we would drain it. Then we would shrink the endometrioma. Then either look at emergency IVF if you've got to move forward with egg freezing, or we would operate then egg freeze. So this is very individualised, this strategy. And if you operate primarily, we check the AMH 3 and 6 months later. And it's very important that if you have endometriomas, they can recur very quickly, and we want menstrual suppression. I don't mind how you suppress your periods, which pill, how, which, and if you got Implanon, but please note that Mirenas do not suppress ovulation, and they're not a great way of stopping recurrence of endometriomas. They're very good at reducing recurrence of endometriosis in the patch of Douglas, on the pelvic side walls, on the bladder, reducing adenomyosis, but it won't help ovarian endometriosis. So should egg freezing be offered to endometriosis routinely? Let's think about it. Endometriosis affects 8 to 12% of women in our community. A significant number of these patients will be infertile. Is it not prudent, and this is a challenge I put to gynecologists, to consider egg freezing in all young patients with endometriosis, both ovarian and not ovarian? It's much better to freeze when you're younger. Should there be government funding for these strategies? Because at the moment, government funding for egg freezing is really strictly for cancer. If you have severe endometriosis with severe ovarian damage, I think that Medicare will allow that to occur, but having endometriosis per se does not fund, or even having a low AMH and having a minimal endometriosis or a normal pelvis does not actually state that you can get Medicare funding. And we really need a sensible and planned approach by the whole gynecological community, and that's where you, as our patients, should be advocates for this. You should be talking to your friends, you should be talking to your family about freezing your eggs. And really, we need to be talking about this with all our patients, having the conversation. So when I spoke to the gynecologist, that I said to them, if you see and operate on young patients with endometriosis, then it may be time that we all discuss egg freezing. And I talk about it with all my young patients. It's not just a patient with endometriomas, because you've got an opportunity to start the conversation with these patients. The age at which the egg is vitrified, that's the term for freezing your egg, is the key. Having the correct information is the key. And one out of left field, and I talk to all my young patients with adenomyosis, if you've got a young egg, will it help you get pregnant with your severe endometriosis? And maybe that can, and at the end that I put, that's a whole other talk that I could do, and I'm happy to discuss further. So Nikki, thank you, and hopefully that's covered a lot of some of the areas, and now we can expand to our delegates and to your questions. Thank you.
Thank you. I had lots of questions. We've got some questions starting to come through. Maybe before we delve into the questions, should we talk a little bit about the process, because that might bring up some more questions, and about if someone was going to go ahead and have their eggs frozen, what would that involve and what would that look like for them? And maybe even how long does that process take from beginning to end?
Yes. So you and I briefly touched on this before, Nikki, and obviously it involves going through IVF, and I would direct you to the Melbourne IVF website, because you can actually see videos and simulations of going through the IVF process. So let's say you've got a patient, they're not on the pill, because we'll talk about that in a minute, and you haven't got a Mirena in, so you have regular cycles. So what happens is that on day one of your period, and what happens is there's always things beforehand, so that people would see the IVF nurses, they see IVF counsellors, and if I could just briefly touch on counselling and the legal aspects of egg freezing, because that's as relevant as the process, in that you get 5 + 5. What do I mean by that? You freeze your eggs for 5 years, and at 5 years you're asked, do you want to freeze them for another 5 years? If you say yes, you're at 10 years. Now, the government then at 10 years, both for eggs and embryos, actually will ask you, what do you want to do with these eggs now? You don't need to freeze this forever, nor should you. And what are you going to do about it? So you can either use the eggs, you can donate them, and a lot of people are donating their eggs. So what's happened is the woman's come along, she's frozen her eggs. 3 years later, they meet their life partner, and they have a baby, might have another baby, and they've got, my God, I've got these eggs. What am I going to do with my eggs? And they will often donate the eggs, because the third option is to discard them. If you want to keep your eggs for longer, there's an external independent patient review panel, so that sits outside the IVF units, where people can go and actually put their case forward as to why they should have their eggs frozen for longer. The same thing occurs with embryos. The only individuals that can freeze their eggs for 20 years are cancer patients, because obviously they're waiting to see how they respond to all their cancer treatment, what their survival is, so they can actually freeze their eggs for longer. But for any other reason, you've got 10 years, and then you have to make a decision or go to a patient review panel. So you get your period, you're in your IVF unit on day one. On day 3, you start a drug known as follicular stimulating hormone. Now, follicular stimulating hormone is what normally is produced by our pituitary gland to actually tell your ovaries to recruit your eggs. So that process happens naturally, but we give you a high dose, and that's where the AMH is very helpful, in that the AMH really started as a test to help guide us as to how much medication to give our patients to try and get about 10 to 14 eggs. Obviously, if you have a very low AMH, you're going to get a lot more eggs. If you've got a very high AMH, we will dial the dose back, because we really want to try and avoid hyperstimulation, which means producing 20 or 30 eggs where individuals can become a little bit unwell. On day 3, you start your medications, and they're injections, which are self-administered. And then you have a scan 5 days later. You then probably have a second scan to see what the eggs are doing. And then your doctor will say, your eggs are ready. So let's say you had your second scan today. We'd say your eggs look fantastic. Everything's the right size. We're going to collect the eggs on Wednesday. So we would trigger ovulation tonight at a very specific time that's timed with your procedure on the Wednesday, and you have a light general anaesthetic. So under ultrasound guidance, we do you have an anaesthetic, we do an ultrasound, we pass a needle. There's a guide on the ultrasound through the vagina into the ovary. We can't physically see the eggs and grab them. They're actually the fluid in the follicles, which is a special cyst that house your eggs, is aspirated, and you'll see that on the IVF if you go to Melbourne IVF. And then the scientists look at, our embryologists look at all the fluid, and they say you've got an egg there, no egg there, and at the end they give you a total egg count, and then they look at how good the eggs are, how mature they are, and then you get the number frozen the next day. And it's obviously a day off work that day. Yeah.
And like you said, you might need ideally 20 to 25.
Yes.
So would you be doing this 2 or 3 times?
In somebody who's got a normal ovarian reserve, you would probably need 2 stimulated cycles. Somebody who's got a very high ovarian reserve, sometimes you get the 20, 25 eggs in one go. Someone's got a very low ovarian reserve, they may take a number of cycles to get 20 to 25 eggs. And you know, people may say, look, I've got 10 eggs. I've taken 4 cycles to get to 10 eggs. I'm happy there. I don't think I can keep going to do another 5 cycles. So it's really very important for us to be communicating with our patients, particularly our patients that respond less because they've got a low ovarian reserve, and about how many cycles they can do, how many they can afford, you know, both physically, emotionally, to keep doing.
Yes. And just to throw a spanner in the works, say you were in your early 20s or early 30s and you had your life partner but you weren't ready to have children yet, could you freeze embryos? Is that allowed?
So that is certainly allowed. There's only one catch to that, as you know, Nikki, because it's a very beautifully loaded question, in that if you freeze embryos, then your partner has equal say on the use of the embryo. So if you separate, the partner can say, no, I do not want you to use the embryos. And my experience after doing IVF for many years is that the majority of partners will say, I'm sorry, I wanted to have a baby with you. Now that we're no longer together, I don't want you to have a child using my sperm in your embryo. So if I have that situation, I'll do what's known, that great Australian term, a shandy, in that we would do half eggs and half embryos.
Okay.
Because it gives our patients, because ultimately it's our patients that we want to provide the maximum flexibility for.
Yep. So you've got a bit of an insurance there.
Yes. Yep. And it's also, I think, sensible, and I've had many patients that will go, they're absolutely sure, but they're just in a situation where they can't have babies at that point in time, but they're with their life partner, and they'll say, they'll say, yes, I hadn't thought about the eggs. Let's do a bit of both.
Mm-hmm. And for a lot of people who've got endo, they are, you know, like you said, they might have Mirena, or they might be on the pill regularly, or they might be on Zoladex or something. How does that impact on the timing and the process of doing this?
So let's talk about the Mirena. So the Mirena, if you have regular spot-on cycles, which not many women do, but some women do, then you just run it like a normal IVF cycle. But most women we know may not bleed or have irregular spotting. So you don't know where you are in your cycle. So I would put those patients on the contraceptive pill for 3 to 4 weeks. They would stop the pill because that's to suppress the ovaries and override ovulation, because we don't know when it's going to happen. And then you would do 2 days after coming off the pill, I do a blood test and a scan to make sure that everything is suppressed, and then we can start the stim. If you've been on the pill long term, it actually suppresses how you respond to IVF, okay? And I think ideally you want to be on off the pill for about 2 or 3 months before you start your IVF stim. Obviously, if it's for cancer, you just stop the pill and go. It's a different scenario, okay? But if you want to try and maximize how many eggs you get, then you should come off the pill. Obviously, some women may prefer to be on the pill and come off it and just go straight onto an IVF cycle, that's fine as well. If you're on Zoladex, you can actually go straight onto an IVF cycle, because very old-fashioned IVF, if you had severe endometriosis before surgery is what it is today, and in some patients where surgery may not be appropriate, that they used to put those patients on Zoladex for 3 months and then do IVF, and they had a higher pregnancy rate than the group that actually didn't have Zoladex for their endometriosis. And one of the theories is that you're actually suppressing the inflammation in the endo. You're shrinking the endo, so probably getting better access to the ovaries. And I believe that you're probably dealing with adenomyosis that really was very poorly understood and very poorly imaged many years ago. So Zoladex is not an issue. And sometimes we'll do, if I've got a patient with adenomyosis who's bleeding all the time and they're trying to get pregnant, I will actually put them on Zoladex, shut their periods right down, shrink their adeno, and move straight onto IVF, because that might be the only time they don't bleed.
Yeah. And people who are on the pill long term or have Mirena and they're wanting to know about their ovarian reserve, that can impact it, can't it?
So the Mirena shouldn't, okay? So I would just do their AMH on, and you can assess the ovarian reserve in 2 ways. I think you should do it both ways. One's to do your AMH, and one's to do an ultrasound and looking at the antral follicle count. So they look at the follicles that are waiting to be recruited in the cycle. The pill, however, can reduce it doesn't reduce your AMH, your number of eggs, but it really makes your ovaries so quiet that they stop producing AMH. Mm-hmm. Now, if you do, I'm happy to do the AMH with the pill, because if your AMH is normal, it's going to be even better when you come off the pill. Okay.
Yep.
But if it's low, I'll say, really, we now need to know what your AMH truly is, and you should therefore come off the pill for 2 or 3 months. I know that's really tough for our patients, because the pill is often one of the key treatments for their pain, suppress ovulation, suppress their periods. But we really want to know where to go, and then they could do their AMH and go straight back on the pill.
Okay. We've got someone asking that they're on Zoladex at the moment. They're only 25. Is there an indication to have the AMH tested at the end of the 6-month course of treatment on the Zoladex?
Can they send a chat in this? What's the plan after the 6 months?
Okay, we'll get them to respond.
Yes. So I think that you could, that individual at 25 should have unless they've had surgery on their ovaries, should have a normal AMH. You can certainly do the AMH during their Zoladex treatment. And if it's normal, that's fine. If it's low, then you want to finish your Zoladex, start cycling and repeat it.
Okay. Something else that you touched on, treating endometriomas. What about superficial or less invasive endometriosis and the impact on the egg quality or the ability to, recruit that many eggs? And
I think that is the most complex question in endometriosis.
Yep.
I don't think we have any reliable recent data on minimal and mild endometriosis, and whether you remove it and whether that improves, firstly, your natural infertility outcomes. It may. Does it improve your IVF outcomes? They used to think so 20 years ago, but IVF wasn't as successful as it was 20 years ago as it is today. And does it actually change your ovarian reserve? We tried to do a study where we looked at women who were having IVF and actually having a laparoscopy, and to see if they had mild or minimal endometriosis. And if we removed it, would it improve their IVF outcome? And we had, because IVF success rates are so much higher now, we couldn't recruit any patients. Okay.
Yeah.
So whilst 20 years ago when you did IVF, because we didn't have ultrasound of the quality we have now, everybody had to have a laparoscopy to exclude endometriosis before IVF. So we had the data many, many years ago. And certainly removing the endo did improve your IVF outcomes. Remember, 20 years ago, your pregnancy rate at 30 was 10% from an IVF embryo transfer. It's now 50%. So if you do a laparoscopy and you get to 52%, is it worth doing a laparoscopy and potentially having an adverse event? Again, we don't have the real data for severe endo, but we have data a bit in reverse, that if you have a woman who doesn't get pregnant on IVF and they've got severe endo, and you remove their severe endo, you get a jump up in their IVF pregnancy rate. So I suspect that if you operated on those patients, that have better IVF outcomes. But I think the current norm of practice is that if you can access the ovaries, that you should do IVF to try and get to pregnancy sooner. But what I don't want to see is patients having repeated IVF treatments and their severe endo is not addressed, because that's the group that may benefit from surgery.
So really, they're just going to have to do a case-by-case discussion with their specialist about what surgery they've had to date, how severe the endo is, the ovarian reserve, all of those factors.
Yes, I think that's very beautifully put, Nikki. What we're talking about now, it's almost custom-made treatment. You have to look at the individual and all those parameters that you talked about, and you almost have a different algorithm for every patient. Okay, what do they want to achieve? How much pain are they in? Where is the pain? How does it relate to their endo? Can you get to their ovaries? What's their AMH? You have to factor all those things in. And I think in many ways that comes down to experience and having a very big practice in endometriosis and seeing a lot of patients who actually have fertility in endometriosis. And I talk to my colleagues both here in Melbourne, overseas, interstate, who have these patient groups, and we think about how can we refine that even better.
Because like you say, for patients who've got, severe pelvic pain, who can't tolerate being off the pill, whilst, the best course of action might be for them to have 2 to 3 months off, really that's intolerable for them. So you're just going to have to crack on and understand risk benefit, that might mean less eggs per cycle, but it's less of a delay and less months of pain.
No, that's absolutely correct. And that's, as you say, it's very individualised.
Yeah. We've got loads of questions, so I better work through them. Someone's asking about having severe endometriosis and also PCOS, and therefore has a high AMH. Is this common, and what does it mean for fertility?
It's common because both conditions are common. So if we say that 10 to 12% of our patients have endo, they say the data suggests that 10 to 20% of patients have PCO. So you're going to have a massive crossover of patients. Okay. So I think it's good if you've got PCO, got a lot more eggs, gives us a lot more flexibility, and you've got endometriosis. The endometriosis can be dealt with on its merits, and in a sense, the ovaries have already looked after themselves. Okay, the group that I think is difficult is you've got endo and you've got a very low ovarian reserve. I think that patient needs to be moving through their options a lot more quickly. So yes, I think it's good to have that combination.
History of ovarian cysts, but no endometrioma. Can cysts do the same thing to the egg reserves, like how you explained that endometrioma damages the follicles?
The ovarian cysts cause much less damage because the endometriomas cause a direct toxic damage to the eggs. There's two processes. One, the expansion of the endometrioma, actually basically crushing your eggs, okay, and a toxic effect into the ovary. Endometriomas, ovarian cysts, unless they're really big, they don't tend to cause as much damage. And when we operate, you get a much lower drop in the ovarian reserve, because an ovarian cyst, I always use the analogy, it's like a balloon within a balloon, okay? And that's a balloon within a balloon, so that the inner balloon that's expanded with fluid is the cyst, and it's expanded the ovary, which is the outer balloon. And basically you slit the outer balloon open and the inner one should shell out with minimal trauma. An endometrioma is not a true cyst, it's a pseudocyst. In other words, how does it get there? endometriosis, in the vast majority of cases, I'll talk about a unique case in a moment, the endo seeds on the ovary. It then drills into the ovary, then the ovary closes over, and then the endo menstruates and grows inside the ovary. So it spreads like tentacles into the ovary. And when you operate, you have to then try and work out where the edge of a normal ovary is and where endometrioma is. So you're cutting more into the ovary than you would with a cyst. There's one unique way that women can develop endometriomas, is that if you ovulate and you get a hemorrhagic cyst, so you bleed into the ovary, most people it'll just go away. But if it stays there, that blood creates an oxidative process, so it actually is a bit toxic to the ovary, and actually the tissue can turn into endometriosis. A very unique way that they described out of Italy.
Okay, that makes sense. We've obviously talked this whole time about freezing the eggs. So someone's saying to use the eggs, you must have to do IVF. Is that the result?
Yes.
Yep.
I'm sure many of our patients online have seen videos on IVF, and you put the sperm together in two ways with IVF. If the sperm is completely normal, once you've got the eggs, we're talking fresh eggs, very important, you drop 20 to 50,000 sperm around each egg and let the sperm get in on its own. If the sperm is abnormal in its quality, in its count, in its appearance, then you have to do ICSI, where you inject one sperm, injecting my needle, into each egg. Now, interestingly, 63% of men actually have abnormal sperm. But when you've got thawed eggs, even though when you thaw the egg, it's lovely, the zona or the outer part of the egg is still a bit hard because it's been frozen. So you have to do ICSI for all those eggs.
Ah, okay.
Very important to know that. Yep.
Yep. So do you thaw all of the eggs that have been frozen and do this?
So no, I would thaw them in batches. So let's say you've got your 25 eggs, I would do half.
Yep.
Okay. And you would then hopefully from 12 eggs, because obviously some of the eggs won't thaw. And why don't they thaw? Embryos are far more robust. So eggs are a single cell with half your DNA. If that cell fractures, it's gone. That's the problem. If you've got an embryo, you've got 100 to 200 cells of multi-potential cells that already have the full DNA complement because they've got sperm and eggs. And then when you thaw out an embryo, even if you lose 20, 30 cells, it doesn't matter because all the other cells are the same and they'll just take over and grow. You don't have that flexibility with eggs.
So you thaw 12, you do the ICSI, and then
wait.
You grow them for the 5 days to become a blastocyst. If you get more than one, the rest get frozen as embryos, and you put one back.
Yes.
Yeah.
Perfect. No, that's exactly right. Thank you, Nikki.
And you said from 12, how many blastocysts would you expect?
You probably get a couple of blastocysts. Well, if you had fresh eggs, you'd probably get 4 to 5 blastocysts because you lose a few eggs on the thaw.
Yes.
Whilst if they're fresh, you've got them there to use them.
Yep. Someone's asking here, is endometriosis in the ovarian fossa damaging to the ovarian reserve in the same way as an OMA?
No, but as we were saying earlier, does endometriosis elsewhere in the pelvis, including the fossa, reduce your ovarian reserve by causing inflammation? A lot of work's going into that area. And as I said, is it the endo has caused a drop in the ovarian reserve, or for whatever reason you develop endo, does it also affect how many eggs you've got? I don't think we know that yet.
Chicken or the egg?
Or both. Yeah.
Yeah, egg or the egg. Someone who is in their early 20s, so under 25, they're saying, if AMH peaks at 25, is there a difference if I freeze my eggs before this, if they've got mild to moderate endo?
No, I don't. Your AMH should still be very high when you're 27 or 28. I think if you should only test your ovarian reserve under 25 if for some reason you are so concerned about your AMH, and that if I couldn't sleep worrying about my AMH, I just get my doctor to check my AMH, okay? Or if I had a family history of premature ovarian failure, of course you check your ovarian reserve, okay? But I would check at 25, and it should be excellent.
Yeah.
I don't think there's a rush then to freeze your eggs unless you've got endometriomas.
A good one here that we have actually not thought about: does IVF make endo worse, and can it create pain flare-ups?
Yes, that's a brilliant question, and I think the answer is yes and yes, whether you're freezing eggs or doing IVF, because what happens in IVF, let's say you produce 12 eggs on IVF. Normally you make one egg in one follicle, and the follicle produces estrogen. That's what drives your endo. And that's why we want people suppressing their ovaries, because their estrogen level is much, much lower. If you have 12 eggs, you're going to make 12 times the estrogen, and it can flare your endo. Also, because if you've got endometriosis and you've got pain, your nerves are going to be, they're almost on alert, for your period pain, for your ovulation pain. And we're then going to stab your ovaries. I know that, but that's what we're doing. We're putting a needle into the ovaries. They're going to bleed a little bit. And so we're going to flare your pain. So we're very cognizant, or I'm very cognizant about my endometriosis patients, about pain relief. Now, the vast majority of our endometriosis patients sail through their IVF treatment and don't change their pain requirements, their pain med requirements. But there are some patients who get flares, and I think it's very important that you respond to those patients. And sometimes you won't know. Some people you think are going to get a big pain flare don't. Others who have been chugging along with their pain meds all of a sudden get a big flare after their IVF. So you need to be cognizant of that.
Yep. And have that as part of the plan when you're
Yes.
formulating the plan, like we spoke about earlier, and when you're going forward with your stim and everything, to have that at front of mind.
Yes. I've only ever had to admit 2 or 3 patients to hospital for stronger pain meds than they could take orally at home. That's unusual.
Yeah. And usually we would, like you said, we would know when that was going to happen. It wouldn't be out of the blue.
Yeah, no, I think I don't think I think sometimes you get caught by surprise. That I think a lot of our patients really manage very well, but then we've given them a surgical insult. That's what a egg collection is. The same thing happens with some of our patients having laparoscopies. You think, it'll be a day case, but I now look at it very carefully and say, do I really think this patient's, if they've been in pain for a long time, maybe we should keep them in overnight at the Epworth. Let's get their first night. The first night of pain is the most critical, because if you're at home on your own, how do you know how much of your pain meds you should take or not take? Whilst with the nurses say, no problems, you should take more. We're here. It's perfectly safe to take more.
Yeah. Yep. I'm trying not to go into too much into people's individual scenarios, but with an AMH of 9 at 20, would that be considered low or high?
That's low, but remember, you haven't peaked. So in a 20-year-old, I would repeat it in 6 months, then a year.
Okay.
Because if that 20-year-old, the AMH is dropping, it shouldn't be dropping.
Yeah.
Okay. But if it's rising or it's the same, then you could just watch it.
And like we said, if they're on the pill, that's going to be.
Oh no, I think if they're on the pill and they're 20, the only way you're going to tell is by coming off the pill.
Yeah.
And you need to be off it for at least 2 or 3 months. I think that's the group where you really don't have a choice. I think to work out what you're going to do for a 20-year-old who's on the pill and an AMH of 9, that you need to sort that out.
Yeah. Someone's saying that they had excision, but they couldn't have complete surgery because they needed a dual colorectal case.
Yep.
So they've still got some DIE and they've had Zoladex. Does the DIE significantly impact their ability to get pregnant with IVF?
No. Well, I'm going to answer it another way. That patient, if you can access that individual's ovaries easily, I would be doing IVF first, because a lot of women will get pregnant. A lot of our patients will get pregnant. But if you can't access the ovaries, then you need to get the ovaries in an anatomical position, and that may mean that you need to sort out the DIE.
Yeah. Someone here that has vaginismus and vulvodynia, they're asking about the options for removal. It would always be done under a light sedation, wouldn't it?
Oh no, it's all under
Yep.
well, you and I call it light sedation, but I look at it another way. It's a formal anaesthetic.
Yep.
That makes you completely comfortable. You can't feel anything, but you're monitoring. I always explain to my patients, the monitoring you have is the same as if you're having 4-hour cardiac surgery. That's the critical part of anaesthesia. It's the monitoring during anaesthesia. So it's specifically designed for recollections. No, you're not awake. You know, there are countries where they do it awake on all the patients. This is not one of them,
including New Zealand.
Oh, okay.
With the diazepam.
Yes, that may be a cost issue because, as you know, in New Zealand, you only get 2 publicly funded cycles. Yep.
I think if you go in the private, you'll get an anaesthetic.
I think so. Yep.
What would be the latest age you would recommend for egg retrieval, and what are the risks of coming off the pill for egg retrieval and endogrowth? We touched on that bit already, but in regards to the age, what would you say?
We used to say 40, okay, but if you saw that data that I showed, that at 42 there's still a chance of pregnancy. And there are some patients who want to freeze their eggs when they're 43 or 44. I say to them, I think that their chance of pregnancy will be close to 0. And I think you want to talk to them about whether they should be thinking about other options, because if they're not in a relationship, maybe they could think about using donor sperm and trying to get pregnant with their own egg, where they might have a 10% chance of pregnancy with a fresh egg.
Yes.
They're not going to have that chance of pregnancy with a frozen egg.
Yeah, particularly after the freeze and the thaw, as you said.
So, I do think that's why I think women now, we should be advocates for our patients that by 30 people should all be having this conversation, and unfortunately they're not.
Someone asking, can you have an egg collection done with the Mirena in situ?
Yes, because the Mirena, you're going outside the uterus. So your Mirena's in the uterus, your ovaries are outside the uterus. So you go up beside, through the vagina, next to the uterus, so we're near the Mirena. And
in regards to the cycle, as we mentioned during the presentation,
you would
your ovaries will keep working. Yeah.
If you've got a Mirena because you don't know where you are in your cycle, you go on the pill for 3 to 4 weeks just to take control of the cycle.
Yeah. Can severe endometriosis cause the outer layer of the oocyte or the shell become hardened to prevent fertilization with IVF?
Are we talking about egg freezing or a frozen egg, or if you're doing IVF and you're using fresh eggs?
I think in general.
So with egg freezing, we always do ICSI.
Yes.
But if you have completely normal sperm, you should do standard insemination, which is where you drop the sperm in. Why? Because the pregnancy rates are actually better with the sperm that makes its own way in than the one you put in, because natural selection is better. We're very
May the best man win.
Yes, or woman, remember?
True.
True, yep. And so, and therefore, I don't think there's any evidence that severe endo affects fertilization rates.
Okay. And does acupuncture or drinking Chinese medicine herbs help to improve quality in addition to CoQ10?
So acupuncture may help. Traditional Chinese medicine may help, but very important if you're using traditional Chinese medicine that you must stop it when you start your IVF, because it affects platelet function. And even if you have surgery, you must stop traditional Chinese medicines a week before surgery or a week before egg collection, because you can really bleed quite profusely.
Yep. Does missing an ovary affect your percentage chance for IVF, or does it halve your chances?
No, it doesn't change your chance of pregnancy. It just halves the number of eggs that you get because you've only got one ovary. Because with IVF, let's say we've got normal ovaries. We're trying to get 5 to 7 eggs per ovary. So you'll get 10 to 14 eggs from a standard IVF cycle. If you've only got one ovary, you'll probably get the number that you would normally get. Giving more dose, one ovary won't make up for 2 ovaries, but you'll still get the normal amount of eggs that you would normally get from that ovary. But it doesn't halve your pregnancy rates.
Yeah, you just going to have to do more times together the number of eggs.
So just on a separate point, people forget about the term cumulative pregnancy rate. What that means is that each time you put an embryo into the uterus, that gives you an X chance of pregnancy. So therefore, X number of people are pregnant. The next month, it's the same pregnancy rate. So the more embryos you put in, the more likely you are to get pregnant. Obviously, now we do stop. I do, after 3 to 4 embryos, stop and see, is there a reason why you're not pregnant? But if we were to just put 8 embryos in a row and not do anything else, 75 to 80% of our patients will have a baby.
Yeah.
But what you want to do is you want to pick that 20% that don't early and see if you can do anything. Yep.
Best timing to get egg freezing if they're heading towards needing the next laparoscopy for possible endo growth, mainly in terms of the hormonal suppression and pain. Will the meds for egg collection exacerbate things? We've talked about that. And like we said, hard to comment on individual cases in regards to pre or post surgery for an egg collection.
I think it's a question of convenience for our patients, because I think that if you remove all the endo, it's not going to grow back with a couple of IVF stim cycles.
Yep.
Or on the other hand, it's not going to grow so floridly that it's going to impact your IVF, your surgical outcomes. If, however, you did IVF for month after month after month after month after month, and you've already got significant disease, I can assure you in a year it'll be much worse.
Yeah.
Okay. I think it's very important to be thinking about those components.
We'll just do a couple more because we're getting to time now. Someone's asking, and we didn't touch on this actually, an idea of the cost of treatment.
Okay. So if you're talking around about, I don't want to make a figure because the IVF providers actually decide the bill. I as a doctor put my patients through Melbourne IVF. Why? Because Melbourne IVF have been freezing eggs for a long, long time, from the time that we had no pregnancies to the time now where we have those pregnancies that we talked about. Because it's not just about freezing your eggs. We now have a lot of babies and a lot of pregnancies, so we know what our pregnancy rates are. Okay, so the prices are certainly much better than they were, as I understand, and there are different strategies as to how you can pay off those cycles. Also, if you happen to be eligible for Medicare, you do get a big reduction in the cost. But as I said, there are only certain criteria outside of cancer that allow you to get those rebates.
Yeah.
So I think it's best to speak to each individual IVF provider, but I do want to implore my patients that they need to be looking at their IVF provider and their experience, not just, I've set up an IVF unit, I can freeze your eggs. I think particularly with egg freezing, you do want a really good track record.
Yeah.
Because we're going to keep your eggs frozen for a long time.
Yes. Yep. We didn't touch on that actually, and that's what I was, when you said you thought I was going to ask a question, we talked throughout about the age of the eggs. What about the age of the woman when they go back?
Oh, that doesn't matter. As long as they're, now remember, you get 10 years. So if you're 40 and freeze your eggs, at 50, the government's really going to push you to use your eggs.
Yeah.
Okay. And remember, if you're over 51, why do I say 51? Because technically you're in your 50th year of life. I know it sounds strange when you go to 50, but as soon as you know 51, you do need to go to a review panel to say in Australia, can I actually get pregnant? I've got my own eggs. I think you would have to get a clearance from an obstetrician. Are you fit enough? Can I carry the pregnancy? What are my adverse events if I was to fall pregnant at 51? But if you were 47, not a problem. If you're 48, you know, there's 51 is the cutoff where our biology can actually have significant impacts on our ability to carry a pregnancy and not have complications.
Yeah. So basically, any time until then,
yes,
whatever the age of the eggs are, that's going to determine your
they're going to lock in. They're going to lock in.
Amazing. What would be the cause of a big drop in AMH if the person does not have endometriomas? Are there other causes, autoimmune issues or something like that that could be impacting?
So not a big drop. I think that, so if you have a big drop, I wonder whether the first result was incorrect. Okay. All right. But let's look at another way. If you're 25 and you have a really low ovarian reserve, then there are autoimmune disorders, so major thyroid dysfunction with antibodies. Okay. Yep. There are very rare anti-ovarian antibodies. Okay. And you can have X-linked Fragile X disorder, where Fragile X is carried by 1 in 250 women in the community, and it can cause severe developmental problems with your offspring. It's one of the tests that people have probably heard of, the PREPARE test, that's done through the Royal Children's, through the BCGS, which is looking at cystic fibrosis screening, Fragile X and spinal muscular atrophy pre-pregnancy. If you're a carrier for Fragile X, often you'll have a very low ovarian reserve. So we would screen for those things, but often it's a family history. You know, my mum went through menopause when she was 30. That's a big flag.
Yeah. What would the AMH be when it peaks in a normal person, you know, non-endo person?
So what's the 50th percentile? It should be sitting about 25 to 35.
Yeah.
Yeah.
At 30 years of age, or?
No, at 25.
At 25, yeah.
Many women will have an AMH of 25 to 30 at 30.
Yeah.
Yeah.
Our
patient with PCO may have an AMH of 65 or 70.
Yeah.
Yeah.
And only need a tiny bit of
just a little bit of stim. Yep.
Yeah. A very niche question. When you remove the eggs, do you do it at a 24 degrees Celsius room with no perfume on the staff?
Yes. Yep. And it gets a bit hot, trust me. And particularly now that we wear N95 masks, when you wore standard surgical masks, they were much kinder. You want, and the eggs. So the fluid that you collect the eggs in sits in a warming tray. So the fluid's constantly at body temperature, and the room's warm, but the eggs only travel through the room from the warming tray to the laboratory for only a split second. It's basically walking less than 3 feet.
Yeah. A good question here, you know, with the medical system being so difficult to navigate, and somebody who's considering egg freezing, where do they start? How do they come and end up at you?
They would go to their GP and say, I want to freeze my eggs. Okay. Yeah. And I don't, or I want to go and talk to somebody to freeze my eggs. And you can get on to the big IVF providers, get on their website. If you like the look of somebody, you know, you would, or I always think the best word of mouth, you speak to your GP, they'll often know. If they don't know, you can ask a friend. And if you, and the liaison staff at the IVF units try and match people to doctors' personalities.
Yeah, perfect. Yeah. And I think we'll make this our last question because it's something we've not mentioned. With the statistics that you mentioned in the presentation about live birth rate, does that change if you've got both endo and adeno?
So I don't think that they haven't broken down. That data has not looked at.
Yeah.
What's your life? Because I can tell you, if you've got significant adeno, your implantation rate is going to be less.
Yeah.
But once you're beyond 12 weeks, your live birth rate should be pretty similar to the rest of the population. It's getting to that 12 weeks. Okay.
Yeah.
To lose your pregnancy after 12 weeks, you really need very severe adenomyosis, and we've all had patients like that. They almost go into labour at 20 weeks. They don't miscarry. You listen to the history, they actually labour. They don't have an incompetent cervix, they actually labour. Okay, that's a very small number of patients. It's that early phase that's complex. And so ask the question, what's the rest of the question? Sorry.
Does the statistical numbers for successful live birth change if you have both endo and adeno?
As I said, they haven't broken it down, but logically you want to be closer to 25 eggs than 5 eggs.
Yeah.
Yeah.
And they affect the different parts of the process. So the endo might affect the ability to retrieve the eggs or store good numbers, and then the adeno comes at a time when it's actually time to implant the embryo and see if that is successful.
And so that's when my last slide, when I said this is a whole other talk, it's should young women with adenomyosis, I talk to all my adenomyosis patients when they're young about when they're going to start their family, and if they're not in a position to freeze their eggs. I think it's very important, because if I look at my patients who've got babies, who've had adenomyosis, they made those decisions very early with their families, with the support of their family and the support of their partners, to have babies when they may not have been in what we may perceive as the ideal time to have a baby. They said, right, this wasn't when I was planning, but having a baby for my partner and I is a critical part of how we see our future lives, and therefore you should be looking at this early on and talking about it. Yeah. It's about talking about it and seriously talking about it, and about talking with a medical practitioner that really takes this seriously.
I think for me, the takeaway from everything you presented tonight is that this is not a one-size-fits-all approach. There's no blanket answer here. Everyone's situation, whether that's their physical situation or, emotional, social, financial, everything, is to be considered in making this decision. And I think, I've had questions that I've not asked you about people who are in their really early 20s. And I think the takeaway from there is that, you haven't peaked yet. There's still time, but now that you've got that information, you know when to pursue it. So
yes, but also I said if I was 23 and I wasn't sleeping at night because I was wondering what my AMH was, I'd just insist on getting a test.
All right. Well, I think we've sucked enough knowledge from you tonight. We're so appreciative for all of your expertise. Pleasure. Thank you so much. And for anybody online who is interested in coming to see me and being pointed in the right direction with one of our endometriosis specialists, or wanting to talk about this in more depth, then my contact details are on the screen. You can submit an inquiry through our website as well, and we'll be in touch. But otherwise, stay tuned to our newsletter. We'll have our next webinar in June, and we'll have another support group in May, which will send the details out in the coming weeks. So there's always something going on. We're so lucky to have such prestigious guests with us sharing their expertise. So thank you once again, Prof. Soltis, for being with us on your Monday night. And
I'm very honoured to be able to speak in this forum. It really is wonderful, and you and the team do a wonderful job, Nikki. Thank you.
Thank you so much. And we'll see you all next time.
Good night,
Good night.